Hello, everybody who is on with us on Zoom today. I'm about to begin in just a very short time. For those of you who don't know me, I'm Johanna Sundby, and I'm an old professor at the Institute of Health and Society, where I've been for a very long time. I'm interested in Africa, and I'm, of course, like everybody else, interested in and concerned with this pandemic. I think I will start now by welcoming everybody to a webinar that will take us into the COVID-19 situation in Africa, particularly Kenya. And we have with us two, I would say, experts on situations in Kenya, Wenzel Geissler and Ruth. And they were in Africa at the time of the COVID outbreak, and they will give us hands-on or whatever information about the situation. I'll lead the discussion. First and foremost, I would like to remind you that this is a webinar in the series of the Center for Global Health and the Pandemic. We are recording the seminars so that when you sign up, you have to be aware that you agreed to be recorded. We will have a 30-minute or so discussion between the three of us, mostly Wenzel and Ruth talking, and me asking questions. And then afterwards, we will have a question and answer session where you can post your questions in written on the question and answer button at the Zoom workshop panel. And we will pick the questions that we think are of biggest relevance and then go down the list and try to answer as many as possible. I would also like to say that this is very interesting because with the pandemic affecting different parts of the world differently, there have been everything from really big worries and then really casual approaches to the COVID spreading out in Africa. And I'm excited about or interested in hearing how things look from that perspective. So the first question I'm asking Wenzel and Ruth, and maybe Ruth first and then Wenzel, is to give some impressions on the COVID-19 situation in Kenya when it started up, when you were still around. So welcome to start the discussion.
Thanks, Johanna. It's really a pleasure to be here, and thanks to the Global Health Center for inviting us to do this. Yeah, so we came back on the 26th of March, I think it was, end of March, and we had not expected to have to leave Kenya. So we were actually stationed out there. We were expected to be out there until end of July. So we actually had to leave Kenya on, actually it was the last plane out of Kenya before the ban on international flights came in on the 25th of March at midnight. And then, so what happened in that month in March was quite, I mean, I guess it was like anywhere else in the world because things happened very rapidly. In the beginning of March, COVID-19 still seemed very far away. So 1st of March, it seemed far away. People were just talking about it a lot because it was on the radio, on TV and so on. But it was in Europe, it was in China. And people were getting concerned about the death rates in Italy and saying, well, you know, what if this is happening in the rich country in Europe, what's going to happen here? So there was fear amongst people, particularly the medical professionals we were interacting with. But amongst other people, it was really, I think there was a lot of joking. There was a lot of joking about coronavirus. It just seemed very far away at that point. And in terms of the country's preparations, I think around on the 7th of March, we met the head of the CDC, that's the Center of Disease Control, the American CDC in Western Kenya, and talked about this situation. And at that point, she said there were 60 tests in the whole region of Western Kenya. So we were in Western Kenya at this point, that's where we were based. And this is one of the biggest labs for the whole region. At that point, it only had 60 tests. And then on the 13th of March was the date that the first COVID-19 case was confirmed in Kenya. A traveler from the US, a young Kenyan woman. And then after that, things happened very fast. So on the 15th of March, the government closed borders, announced school closures during the next week, college closures, and yeah, big clampdown on mobility, on closing markets, and there was also a lot of protest about these things. Do you want to continue?
Yeah, I would like you to also give a little bit more information about the public responses. Like, what did the governments around in Kenya, or the central government, do in the first weeks as well? Maybe Wenzel can continue where you stopped and take that part into the discussion to the public response to this.
Yeah, thank you. As Ruth said, it was probably like everywhere in the world a strange experience of things happening very rapidly. And it's quite difficult in retrospect to figure out what happened when and in what sequence, because things, you stood up in the morning, you made a plan, some information came about some government action, you changed your plan a bit. And so it went like this day by day. So it was quite a hectic and rapid transformation. The first government measures that I remember, because they sort of affected us, was the closure of schools all over the country, which at the time seemed like a slightly abrupt and little thought through measure, because unlike Norway, where you have students going from home to school, you have most of the older children in Kenya in boarding schools. So the day this school ban, school closure came into force, you had literally 5 times as much traffic on all the national roads, because all fathers and mothers were traveling across the country, if they had their own car, to get their children from school, and all the children with parents without cars were on buses and motorbikes, crammed, traveling in the opposite direction across the country. So that was one of the first sort of obvious measures, which seemed at the time slightly attractive.
Something happened here. We couldn't hear this.
What was the next?
Well, the government marched these closures of schools and markets and so on. And then when it announced the closure of markets, there was big protests, because many people in Kenya are dependent on leaving their homes, their houses every day and going and selling something by the side of the road, market, or so it was really, very essential to people's livelihoods all over the country. So there were protests and backtracked a bit on this market, but then sent around public health officers to disinfect markets. So in the next week, there were these public health officers going around, sort of clearing markets, disinfecting them. So there's a lot about people, and then you immediately also saw just this, where a city usually was completely crowded with people selling stuff on the sides of the street, then this was very quickly empty, enforced by the police, which we'll come to later. So those were really kind of striking measures, and then the government soon after that announced some kind of economic, financial protection measures, for example, tax relief and a moratorium on loans. A lot of Kenyans get loans out and are in debt, especially middle-class Kenyans. And the government announced a 3-month moratorium on loans and some other kind of tax relief measures, which was then very quickly criticized for only helping the middle classes. So the government response was also very much in the beginning kind of directed towards this middle class, protecting the middle classes and imagining protection of the middle classes who could stay in their homes, who could, many of them actually work at home, especially government workers. But government offices also closed.
So was it a real formal closure imposed on Kenya, and then difficulties in having that really implemented, or was it a partial closure?
So it was there wasn't a lockdown, so the people were not told to stay in, they were told to work at home if they could, and then they were cleared out from the markets and so on, but it was difficult to impose a lockdown making people stay in their homes. And that's why they introduced a curfew on 29th of March, so that this was the day after we left, a couple of days after we left, a curfew which is still there from 7 p.m. till 5 a.m. And that curfew was accompanied by a lot of police violence. And so there's a lot of criticism, a lot of critique in Kenya amongst Kenyans about this police violence in pursuing the curfew. So in the first days, there were reports about how many people were being killed by the police, and a lot of commentary on that. So day one of the curfew, someone is blogging, commenting on social media that, okay, day one of the curfew, 1 person dead from coronavirus and 5 people killed by police. So there was a lot of critique about the kind of also collusion between the government and the police in enforcing this curfew in many cases very violently, and people were really quite scared about the police as well, scared to move around. Ordinary people just encountering violence and coercion. And there was also the threat that if you were caught after curfew, you would be arrested or put into quarantine and fined.
You guys have been working on understanding the development in the health sector in Kenya for quite some time. And what you're talking about now is a lot about the government's response and doing kind of like non-health interventions. Curfew, locking downs, closures, and things like that. Wenzel, it has been a bit difficult to hear you, but would you talk a little bit about the development in the health sector in Kenya so that we understand that type of context when it comes to the response to the threat of the epidemic?
Also,
we can't hear you well. Maybe you could move to Ruth's computer.
right. I mean, you mean in the health facilities, Joanna?
Yeah, health sector and health facilities. What is the state of the art right now? What is at stake? Like, that's overall there, and that has to be there through the epidemic as well.
Well, an overall outlook you can't really get from me, because I was at the time in these 3 weeks that we still were in Kenya, mainly in one peripheral health facility. So I couldn't speak for the entire health system or even for higher level facilities. In that small facility where I worked throughout that time, initially there was a great lack of information. People didn't really know much about Corona, and which then was very, very quickly and efficiently caught up on by the county health management. And gradually information trickled down from the top, from the facility managers, to the lower levels. And I think that process was interesting, because as the lower levels were still wondering what's going on and joking about Corona, on the higher levels there were preparations being made for Corona screening, and some considerations of protective measures. But during the time we were there, as for the screening processes, for example, most of what I saw was improvised on a county level or lower, in the sense that the facility managers would produce some screening protocols for patients, which would in principle allow to zoom in on potential Corona patients, but there was at that point no clear coordination of such protocols. So, for example, there was a protocol used for 1 week where all patients coming to the facility would be asked whether they had a temperature or a cough and had traveled internationally, which in a facility 150 kilometers from the next city was a relatively unlikely event to be found. So, the screening tool was there, but not really efficient. The same applies to protective measures, in the sense that most of the peripheral facilities had none and had to improvise in various ways. So, for example, in the facility where I worked, which was a
very near the Ugandan border, they discovered they had some old Ebola equipment, which they could recycle for the purpose of potential COVID-19 patients. Whereas in other facilities, there was none such things, and they had to wait for another month after we had left before they were given protective equipment. So there was great variability, but at the same time also great commitment from the staff to make things happen, to get on with things and prepare for a potential outbreak. Did you want to say something?
Yeah, maybe Ruth, do you want to continue?
Can you put yours on mute? Yeah. So yeah, what was happening? Well, I think we also need to add what the community health workers were doing in that facility or in this rural county. So the perspective of community health workers at that point, and then I can talk later about health workers at other levels, but really I think throughout March, community health workers had been given no information specifically and no training about COVID-19. What they had heard about it was from the radio, from other sources, but not directly from the government, whereas other health workers had been taken for trainings at central points. So the community health workers were complaining at that point that they didn't know, or they were asking a lot of questions, and they were saying, we're the people who are walking around, and we need to be able to know what to tell people when they're asking us about it. So there was increasing concern amongst the community health workers in March. And then when the first case was discovered on the 13th of March, then I think things became more real. And so at that point, that week, all these health facilities, rural health facilities, rural hospitals, water was being delivered by an NGO, water in a container with a tap and soap. And they were asking everybody who walked into the compound to wash their hands. And community health workers were being involved there. And then they also were very quickly involved in the tracing. Do you want to talk about the tracing of the first suspects? Yeah, in Siaya County.
Sorry,
Yeah.
Okay. So we can talk about tracing, about tracing and testing later. But so they didn't really. They felt that they were not being that their expertise was not being really acknowledged in the beginning. But I think this changed quite a lot in towards the end of March and in April, when the first cases were also found in rural parts of Kenya and also in this county, with somebody who traveled from Mombasa and somebody who traveled from Nairobi. And then the county health management team very quickly kind of kicked into action and followed this protocol for tracing what they call suspected cases, and using community health workers to follow the contacts. So this person had traveled to a funeral in this rural area from Nairobi, originally from Italy, but a Kenyan man. And so all the people who had been in that funeral were contacted, and the community health workers were also responsible for tracing them back to their homes and taking tests, bringing them in for testing. So the whole.
Did they also practice quarantine for those that were at risk?
Yeah, so that was also being developed in so that at that point in March, end of March, they were still kind of actually making these isolation wards and finding places to isolate people. So they would, the government all around the country was identifying like boarding schools, polytechnics, which were now empty of students, to put people for quarantine. And then, yes, they did put people into quarantine. And this often done, there were a lot of rumors at that time that they were charging people quite a lot of money for being in quarantine every day, like 2,000 shillings, which is about 20 euro a day. And people were very scared about that because, yeah, many people couldn't afford it. So this was also had its effects on people being scared to go to the hospitals, people being scared to go to health centers because they thought that they, if they were tested or even if they had a temperature, they would be taken into isolation and possibly quarantine.
But during this first time of the epidemic, were there any significant number of deaths, or was it still a a country working to prevent, like in the beginning of the epidemic in Norway, we were very concerned about like flattening the curve, as they call it, like postponing the overflow of the main hospitals with serious cases and fatalities and things like that. Well, how was that in Wenzel? How was that, do you think?
Well, there was, as you suggested, there wasn't really a curve in Kenya at the time. There was one patient here, one patient there. There was seemingly relatively little transmission from those first cases to other patients. So yeah, flattening the curve wasn't really the aim early on. Sorry, you were saying?
No. Yeah.
So Ruth was talking about the isolation wards. The patients, the isolation wards were not ready initially, but were ready about the time when we left. And I think by last week in the county where we worked, there was one patient in the isolation ward. And yeah, that was it. So there wasn't a large-scale quarantining of contacts of the initial cases in the area, which is not so surprising because for most people, being 14 days in quarantine would not only be a mess for themselves, but also for the rest of their families, and would be avoided by all means. So I think in addition to the anxiety about Corona, the infection, and the anxiety about police violence and enforcing curfews and lockdowns and so on, the idea of being quarantined in places that were potentially high risk and in places where they couldn't continue their normal breadwinning activities was a nightmare for most across classes really, but especially for the lower classes in Kenya. So it really contributed to the scare around COVID rather than alleviating that scare or making people feel comfortable in a very different way from how you maybe would experience this here in Norway.
Did the health services in general keep going like they used to, or was it a big focus on healthcare around the COVID epidemic, and then things like antenatal care and curative services and all those things? How was that balance, Wenzel?
Well, during the time we were still in Kenya, everything seemed to go on more or less as normal. In the very end, before we left, sort of about 3 weeks into the epidemic, you could see that fewer people were attending the clinic. And then 2 weeks after we left, we got reports that very few people were coming to the clinic. And especially, as you just mentioned, women would avoid coming to antenatal care, and overall numbers of facility deliveries would be down. So there was clearly an effect, which was probably owed partly to the fear of getting infected at the hospital, or maybe greater fear of being identified as a potential suspect and being quarantined or arrested, as they would call it, in the hospital. So both contributed to a great reduction of outpatients and mothers coming in for ANC and delivery. And sorry, but most recently we heard that actually things calmed down a little bit, and people realized, well, there's no new cases in the county, so numbers of outpatients have been picking up. Do you want to say?
Yes, because you have followed the developments from afar and kept in touch with people and you know a little bit more about what's going on now. Can you update us about your current situation on the epidemic in Kenya? Do you have any information that could be useful to understand how things have developed?
Well, through social media, you get inevitably quite a limited kind of impression. One strand of social media posts that comes a lot has to do with small community-based initiatives to prevent transmission. So, for example, there's local production of face masks, local distribution of face masks, and those kind of things. Hand washing, Ruth already mentioned. So there's quite a lot going on a community level, encouraged by CBOs, NGOs. Often, interestingly, by CBOs that were generated or came out of the AIDS epidemic and now took on a new role in the COVID epidemic. So there's that, and then there is a great deal of crazy rumoring, similar to other parts of the world, I suppose, but a bit more extreme, about the origins of COVID, about the problem of vaccination and vaccination trials, and a lot of fake news around that. Maybe we can come back to that, because I think it's an interesting aspect of the African epidemic, in particular, this rumor mongering and strange ideas to do with racial relations in relation to COVID.
But maybe you can elaborate a little bit more on that, because you've written some interesting things about rumors that this is a disease that comes from the white man coming to Africa.
Yeah.
And can you talk more about that, both of you? Maybe Wenzel first and then Ruth.
Mm-hmm.
Yeah, it is an interesting aspect. I remember one of the first moments when COVID sort of penetrated into our study area was when I was together with a young man moving about our study area, and he, with great energy and joy, kept mentioning Corona and laughing loud when he said that. And at some point I asked him whether he wasn't afraid of Corona, and his answer was that, no, because it's a disease for white people that wouldn't harm him. And he then elaborated a bit on why it wouldn't harm him, but it was clear that it was a disease for white people. So that was the beginning. But then quite quickly, people realized, well, okay, it was possible for Africans to get the disease. And the next thing we experienced was that nobody was ever outrightly hostile to us, but there was an implication as to that we were the ones, we as European visitors, potentially bringing the disease. So people would point at us and say, for example, they called us Corona, and I think other Europeans in Kenya have experienced the same. They would say, like, Corona, how are you? Or Corona, go home, which, wasn't hostile, but slightly uncomfortable. It was joking, definitely, yeah, but it was slightly uncomfortable, and it was above all indicating that this disease was perceived as something that comes from outside, and quite correctly, Europe was made out to be the epicenter from where the disease would travel, and it would travel through white people or through middle-class people coming back from Europe, and then through city dwellers back to the rural area. So a very different kind of trajectory from the one that, for example, Ebola generated, where the idea was that some bushmeat eating people would bring it from the forest to the human community, and then from the village to the city, from the city to Europe. And I think in that regard, the disease is very interesting, because that triggers different kinds of rumors. You wanted to?
But Kenya and other African countries have vast experience with different epidemics. Maybe not so much Ebola in Kenya, but definitely the HIV epidemic. Does that give them an advantage in responding to this, or is it completely separate? Is it the same response, or do they use the same types of responses, or is it a new situation now?
I think that's a very interesting question. You have to put your sound off. Yeah, it's a very interesting question, because what do you do when it's a new epidemic, it's a new disease everywhere in the world, and there's no clear scientific sort of consensus about how to deal with it, apart from these old, well-tried, century-old measures of quarantining and social distancing. And therefore, what do? You do turn to what has been used before. And I think that example of using the Ebola kit is one example where, or a protocol about identifying possible carriers using the Ebola protocol and adapting it is an example of how one epidemic kind of is used to understand another one in some ways. But in terms of the HIV/AIDS epidemic, yes, I mean, it's still, of course, Kenya, many more people infected now with HIV than with COVID. I mean, COVID is an anticipated epidemic, but at the moment there are 700 cases, 700 or 800 cases in Kenya. It's nothing like in Europe. And of course, those are the ones who've been tested. And of course, many people say there are many more cases that haven't been tested. So it's more of an anticipated epidemic, whereas HIV is definitely there. I think we don't know yet, the detailed answers to that question, but it's interesting that what HIV has left behind is actually a very strong community-based organization and community-based groups, patient support groups, self-help groups, and all these groups, and we've been in contact with some of them also after we left, you know, they are really mobilizing in response to this. So doing a lot of information, going around their communities, telling people about what to do, telling people about washing hands. Also, as Wenzel mentioned, making masks, selling them for a small amount of money, also to generate some income. I've been in contact with cancer support groups, which are very, I mean, they're very, not many compared to the HIV support groups, but they're also kind of sharing a lot of information also through WhatsApp. So I think these kind of community-based patient support responses that were left by other epidemics, and especially the AIDS epidemic, will be actually very important. You know, are important now, and are and maybe more important as this continues. We don't know how it's going to continue. And I think that's also, you know, in part the strength, because of course, you know, people are the Kenyan health system is of course much more fragile than the Norwegian health system, and there's huge systemic issues. But at the same time, there are some strengths, and there are some strength in what is existing and what has been used before. I think one big issue that the Kenyan health system is facing in response to this crisis now is the question of health workers, because there's been a lot of strikes over the past year with health workers being very disgruntled, not getting their salaries on time, not being able to pay their school fees for their children. So a lot of demotivated health workers, and that's of course a big issue now. And then they're still threatening to go on strike because they're not getting enough protective equipment, and there's a lot of fear. But as I said, you know, this is more of an anticipated epidemic in a way, and what Kenyans are experiencing much more in their daily lives is the anti-epidemic measures that influence that put a stop on mobility. So, for example, when Wenzel mentioned the maternal deliveries reducing, I mean, one other reason why they reduced was because women simply couldn't find people to take them to the hospitals, because there were no motorbike drivers doing it, because they were also scared of the police. So deliveries at night became, or probably still also, very difficult to get there. The motorbike driver would be afraid of being stopped by the police because he has no reason to be out at night. And so we've heard many cases of women not being able to get to the health center at night.
Is the healthcare system in Kenya mostly public still, or do you have a two-tier health system where a lot of the middle class now tend to use private facilities? How is that developing in the background of this?
Yeah, so Kenya has a very bifurcated health system, or there's a public health system, which has in the last decades really suffered from lack of resources, and has become largely orientated to people who don't have the money to pay for private healthcare and don't have the insurance. So most middle class people would avoid public hospitals and clinics and use their insurance card or their own pocket to pay for healthcare. And I think I'm not quite sure what's happening now in relation to this, but I do know that, for example, with maternal deliveries, when mothers were worried about going to public hospitals to deliver because they're worried about getting COVID, they're choosing private hospitals. And private, also these small, not necessarily expensive private hospitals, but also these small clinics run privately, also by NGOs, and because people perceive those as being safer, that they don't take corona patients, they're not doing quarantining, they're not isolating people there. So there's something is happening there regarding maternal deliveries, and in terms of access to better care in private hospitals, yeah, I mean, this is incredibly bifurcated in Kenya, but it's a good question, you know, how many ICU units are available in private hospitals compared to public hospitals. I don't know that answer, but it's an important question.
I think we now will turn a little bit to the listening audience, and we have already have some questions posted, and I urge you to post questions on the Q&A button at the bottom of the page here. We'll start with one, Wenzel. There's a lady here who wants us to elaborate something about the health literacy level in the population in the area where you were. Specifically relating to the COVID, but also how adequate or inadequate level of health literacy affect compliance. I mean, do people understand this? Do they understand virus? Do they understand epidemics? All those things. Can you say something about that?
Well, it's quite difficult to speak about health literacy in a general way, because Kenya is such an enormously diverse society, and I wouldn't want to venture into some general kind of points here about lack of literacy or not. I think what is striking is what Ruth mentioned before, is the kind of literacy that is generated by HIV and by HIV interventions that has prepared people for this epidemic. When HIV struck, it took years, rather decades, for people in the rural areas to open up to, or even get information on biological, biomedical processes behind the disease. There was lots of cultural interpretations, you might call them, which lingered on for decades. Whereas in this case, I think the general population is much more tuned into getting up-to-date information. Social media play a great role in this, but also just the fact that there are those community-based structures that Ruth talked about, which help people get information very quickly. So just to give you an example, even villages would have some villages would come up with some percentages of relative protection offered by different types of face masks within a week or two into the epidemic. Whereas in the case of HIV, it took 10 years for the president to acknowledge that the disease existed, and another 10 years for villages to acknowledge that it wasn't something to do with infringed taboos. So I think in that way, literacy, in the sense of willingness to pick up new knowledge and engage with it, is very high, which is a great chance. And that is really a contrast. When we worked in Kenya in the beginning of the HIV epidemic, and tried at the time, in our studentish, humble ways to convey some health information. And I think the kinds of dialogues that we would have now compared to then with villages were very different. So I think rather than literacy is maybe about willingness to acquire literacy and to learn and to talk, which is definitely higher today than it was.
I read once that one response to this epidemic would be to look at how the world had responded to the previous epidemic, especially the HIV epidemic, with engaging local communities and having dialogues with affected people and a lot of other preventive measures and curative measures. This lady also follows up with a question that says, how was the response by the health authorities? They have had a couple of decades experience with tailoring messages to the audience around the HIV epidemic. Do they have any, would you say that the information that they gave out in the beginning of the COVID epidemic was tailored? Was it very general, or did they go into the specificities? Did they use audiovisual media or such things?
The first information you got in Kenya about COVID was a text message from the Ministry of Health to your mobile phone. And many people own mobile phones in Kenya. I think it has the most dense use of mobile phones. So even if maybe not every individual has a phone, definitely not, but as one in the household. So mobile phone is now a very good way of reaching and giving people information, and the Ministry of Health was using that. We got updates every day, and often the same messages, very simple messages. COVID-19 is a viral disease. It's passed through coughing. Symptoms are fever and coughing. You must wash your hands prevention is washing hands. So those simple messages were put through text, and then also radio. So a lot of, I mean, the radio, local radio at this time was just very dense with discussions about COVID and COVID messaging. So I think the government had, I think, again, you know, building on the experience of the HIV/AIDS epidemic, there's a very good system of actually giving information out about health issues. And then also through the whole health system structure, you know, from the different levels down to community health levels. As I said, community health workers for the first few weeks really did feel they were not being given any special informational trainings, but that changed. So it was kind of slow, but then the structure is there and it's kicked into action. I think it's been quite effective. I mean, it's really quite striking how everybody knew about COVID-19 in also really remote places. And you should also remember that Kenyan villages are not, at least in Western Kenya, there's a lot of migration between rural and urban areas. So, you know, you would get teenagers in these villages with smartphones, you know, maybe visiting their relative from Nairobi or just living there. But people do have smartphones, people who maybe don't have much else, but they will own a smartphone, especially the young people. And so, of course, that was also, they also had access to social media through those smartphones. And then, of course, through to fake news. And fake news was also a big issue and is a big issue. And the government is also taking up, just like everywhere else in the world, the problem of COVID being an epidemic of fake news.
There is another question here from a listener who asks questions around that are typical for epidemics and diseases that are affecting some people, and you have to isolate them and you have to put a kind of label on them as being dangerous to others. How does discrimination and stigma act out in this epidemic from healthcare workers or from the community? Did you have any impression of that, or is that something that comes later, you think? Like you said that it was seen as a white man's disease, which is some kind of putting a stigma to the white people, but I guess there's more to it than just that.
Mm. Yeah, so there were a lot of Chinese in the beginning. I think Chinese were also being labeled, and I think there was at least one instance of violence against somebody looking like they were Chinese in Kenya. But this is now, I think there's now a lot of discussion about stigmatization, which is surprising because it's very different from HIV/AIDS in terms of in terms of how it spread and how easily it spread. But there are discussions about stigmatization and the problem of people with COVID-19, the few people who've had it or have it, then going back to their homes, their neighborhoods, and being somehow ostracized or accused. So I only know about this from newspaper reports and social media since I've been back, so I can't really give you a very good impression. I'm sure if you talk to someone in Kenya, they would have a much better idea about it. There's the other issue was funerals, where the government introduced very early on, again mid-March, they stopped funerals of over 15 participants, which is a huge thing in Kenya, where you have usually funerals should be attended by hundreds of people, otherwise it's not a good funeral, and there's a huge amount of mobility with people moving around the country to funerals. And anyway, there was one incident of a person who died of COVID being buried. This is in the rural area where we were based, but it was after we left. And just being buried by the public health authorities very hastily, without any funeral rituals, the family not being properly involved, no priest, and a video was taken of it, and it went live, and there was a huge amount of protest against this, not really giving somebody the dignified burial they deserved, and this was a huge concern in relation to the kind of COVID-19 burial practices. that were being followed by the government.
I also see here a couple of questions from the audience on the epidemiology of the epidemic. That you guys are anthropologists, but I guess you may have some thoughts about how accurate the registration of the spread of the disease is in Kenya, whether the reported case numbers are accurate, that some reasons why the case numbers haven't skyrocketed like in other countries, or whether there are lots of cases of COVID infections that go unnoticed because it just looks like any other disease. Like, where's the epidemic going? It's a curious thing from me that it came via Europe and not directly from China, given the big interaction between Africa and China. But that's a different question. But a little bit on the progression of the disease in Kenya. Maybe you, Wenzel, can address it a little bit.
Yeah, I don't know whether I would dare to do so, because, as you know, even epidemiologists are quite unclear about the figures. Testing is not done large scale in Kenya. Reporting structures in the health system are very weak, and whether what you would require to really get an idea is a system able to pick up, for example, a cluster of respiratory related morbidity. And from my very limited experience with the health system, I would be surprised that would happen before a very significant number excess deaths have happened, which would mean weeks or months until, from a facility level, reporting moves up the chain in order to identify new clusters of transmission. So given the weakness of the reporting chain and the absence of testing, I think the figures we have of transmission are doubtful. But I think beyond that, epidemiologists would be able to say a little bit more, but also not so much more, because it is a very unclear field. It's what is clear, though, is that this rapid, explosive kind of curve that some people speculated about would happen in an African country with a weak health system, with high mobility and great population density, didn't seem to have happened. 5-6 weeks into the epidemic, we don't see 10,000s of deaths. And I think 10,000s one would probably begin to see, even in a system that has its weaknesses in terms of visibility and reporting.
So do you think that will affect the way the population in Kenya sees the disease? There's one person here who wonders whether COVID-19 is being perceived as a dangerous disease, or maybe just another disease that we have, like traffic accidents and HIV and TB and malaria and cholera, and
I think that's a very interesting question. Sorry.
Yeah, come on.
I think that's a very interesting question, because I think that already now we can see that it shifts very quickly how people perceive the disease. And that has something to do also with, going back to your question about HIV and Ebola and other epidemics, preparing the population for this. It has to do with how it is framed. For example, when in the beginning of the epidemic, there were lots of public kind of situations where Ebola protective gear was used to stage, for example, the spraying of a minibus in which one contact or one patient had been transported. Those pictures evoked Ebola and evoked very acute threat and panic among the population. You saw, a disease with like Ebola with a 30-40% case fatality, and people were panicking. Also, the parallel with AIDS gave people a certain different kind of panic. I remember, for example, in relation to the funeral that Ruth mentioned, this very undignified, brutal, nightly dumping of a body, people were saying, oh, well, this is like AIDS, it's going to be like AIDS. It's going to be as bad as AIDS. So in those moments, there's great seriousness. But as you say, I mean, one could well imagine a development in which people in a couple of weeks realize, maybe in a way quite realistically, that there are 100 other more serious causes of mortality in Kenya, and that in a relatively young population, the mortality, a mortality of 2-3%, or let it be 8% in a weak health system, is less dramatic than the already ongoing morbidity from other causes, infectious and non-infectious. So I think we will see a much more rapid fluctuation of and diversity of serious, non-serious kind of perceptions. Maybe not so different from how it is here. I mean, I think here too we go through moments of panic and moments of partying, sudden sort of relief that it's not as bad as we thought it was. So I think Kenyan responses won't be so different from those we see around us here.
But now that that some countries in Africa are strong on lockdown, and some countries like Malawi has said that lockdown cannot be done in Malawi because people can't live with the lockdown, and then maybe this disease in Kenya not being as serious as some people predicted in the beginning, because they thought because the health systems and the people in Kenya are vulnerable, it would be like a fire. What direction do you anticipate that Kenya will take? Will it continue to have lockdown and curfew, or would they open up? Ruth, maybe, do you have any messages from your friends on those issues? Where will we go?
Kenya is, of course, incredibly dependent on the tourist industry and on trade with other countries. So closing the borders has really affected people that trade at many levels, and also people who just move across the border with Uganda or Tanzania to trade goods. So this is having a serious effect, and I can't predict what the government is going to do and how long it will keep international. I think the government's probably looking at what the rest of the world is doing, which it seems to have been done in the last weeks, looking at what the rest of the world is doing and following suit after careful consideration. I mean, the Kenyan government, I think, really responded very, very quickly to this, very quickly, much more quickly than the governments of the UK and the USA. And that quick, fast response has actually paid off, it seems. And that's what epidemiologists I've been talking to in Kenya, people in hospital managers as well, are saying that this seems to have paid off. So maybe it's going to give people a confidence in government public health strategies in a way. At the same time, we've seen people have also seen the dark side of state coercion and police brutality, and are angry about the markets being closed and all this. So I think there's a kind of potential for protest and unrest that the government is probably also looking at. And I see somebody else has also asked about what kinds of has the government introduced any financial help to low income groups. I mentioned that there was this tax relief and help with loans, which helps middle class groups, but not people who can't get loans anyway and don't have salaries. I'm sure. I don't know of any government moves to help really vulnerable populations. I think there has been some food relief, Red Cross and other organizations handing out some food relief in some places. But I'm not very well qualified to answer that.
We're going to wrap up quite soon, but there's one remaining question I would like both of you to respond to, and maybe also round off this discussion, because now that we are facing maybe more knowledge and science around this epidemic disease, there have been requests also in Norway for people who've done clinical trials in Africa, and I think in the next couple of years there will be a huge need for clinical trials on various aspects of this disease also rolling out in Africa. What is your view on rolling out clinical trials, both on vaccination and maybe also on treatment regimes in a country like Kenya that doesn't really have a huge burden of disease, but where a lot of people think it's easier to roll out trials in poor countries than in rich countries? I don't know the ethics of that. maybe both of you can round off by talking a little bit about that, and then maybe rounding off the discussion in total. We have another
maybe
5
I
minutes.
could say something about the trials, because again, I think it's difficult to predict how things will develop, because especially in this age of social media, things can happen so quickly and opinion can change so quickly. But what we've seen in the last weeks was really quite intriguing, in the sense that there seems to be quite strong, I mean, very strong resistance to clinical trials of COVID vaccination or drugs in Kenya. And no, it's always difficult to draw conclusions from social media, because whether people believe them and how many people actually see them is another question. But in the area where we work is probably the largest medical research center north of South Africa, in sub-Saharan Africa, in Kisumu, run by the Kenya Medical Research Institute, funded mainly by the American CDC. So they have experience with clinical trials for malaria vaccines, for HIV drugs, for HIV treatment and prevention regimes for about 30 or 40 years. But rather than this leading to people saying, oh yeah, sure, we know what research is, let's go on with it, it seems to have built up an irritation and a resentment against international research projects, to the extent that the social media flows in response to possible clinical trials against COVID, for COVID drugs, is quite extraordinary. I mean, really aggressive, lots of memes with either Kenyan dignitaries or international figures saying, you know, Africans should no longer be used as guinea pigs. The Bill Gates tries to castrate the Africans or murder Africans with his vaccine. And these are very widespread. They are partly very crude and partly more sophisticated, but they will definitely be a huge obstacle to clinical trial rollouts.
Okay, and you, Ruth, do you have a final comment in this discussion? Or commenting on the issue of vaccination and trials?
Yeah, I think Wenzel's said what can be said about that. There's a lot of information going around, and a lot of discussions. I mean, one thing that Kenya has a very, very robust kind of critique, public critique, also within the middle classes on WhatsApp and social media. And there's a lot of information going along, a lot of criticism going on, and also amongst people who are not using social media. You know, there's just quite it's a place. I mean, I guess like anywhere in the world where people are discussing and scrutinizing. And I think that COVID has exposed some of these inequalities that were, you know, people knew were always there, but they've opened them up. They've opened up these issues about how the government is protecting the middle classes but not protecting the rest of the country, and so it's interesting to see, you know, what will come out of this in terms of also, you know, any calls for greater state protection of vulnerable populations, which the state has been kind of moving towards slowly with help from outside donors, but quite slowly. I mean, there are social protection programs, cash transfers, the government's moving towards universal health coverage in some way. But whether this will be interrupted by COVID, whether there will be huge reduction in global health funds for a country like Kenya, which really depends on donor funding, for example, for HIV/AIDS treatment. I mean, I think this is something it's really a crucial year to see what is actually going to happen in terms of the kinds of public health services and support that the state is able to give.
I think it's very interesting to compare this disease with the response in HIV/AIDS, because for both of those two epidemics, the initial response has been entirely to work on prevention, and to work on prevention in communities and with low tech, like face masks and condoms in a way, and behavioral change and behavioral constraints. And then there's this extreme contrast to the very, very high-tech responses that developed in the HIV epidemic on antiretroviral treatment, and also still exist for the severe cases in the West of COVID-19 with high-tech intensive care in specialized units. And then still it looks as if, I mean, people are less, or people are willing to do the behavioral change very quickly in this disease here. They are actually listening to social distancing, physical distancing, hand washing, all those things everywhere. And it would be a very interesting future, and maybe we can discuss that at a later stage, and how that will, which ones are the leads that we actually should follow, and how much do each of these types of approaches play in. We've come to the end of the webinar, and I appreciate the conversation we've had. I hope you learned a little bit about it. We couldn't answer all the questions, but maybe we can do some of that in writing. So I'll thank you. Thank you very much. And thank you for all of those of you who listened. Maybe we'll see each other in a few months' time with the follow-up. That would be nice.
Yeah, thanks for the questions.
Goodbye.
Thank you very much.